Good morning.
Welcome to Project Echo Cardiology. So we're going to be talking about heart failure with preserved ejection fraction, but I want to make sure, as always, and then we have some, but I want to make sure, as always, that anyone who has a case or wants to talk about patient stuff has the opportunity to do so.
Any cases out there? No.
Excellent. Okay. Good deal. Well, we'll definitely be able to fill our time with the. Now, do you get those? Awesome. Okay. Great. Okay. So let's start with we'll start with EKGs. Excellent. So I've been going through EKGs at a pretty high level, and I'm going to take a step back and review a couple of things here. But again, when you're looking at an EKG, the last thing you want to look at is ischemia, which is the first thing that often will catch your eye. But so rate, rhythm, axis, intervals, hypertrophy, and ischemia is the general way that I look at it. There's other ways you can subdivide it, but those are the main topics you want to hit. So rate. So remember that one little box is 40 milliseconds, and one big box, or 5 of those, then of course is 200 milliseconds. So you can catch the rate on the rhythm strip or anywhere in the EKG between 2 QRS complexes by counting boxes, right? So if the if there was another QRS here, then that would be one big box apart. That'd be 300 beats per minute. 2 big boxes, so the QRS is here, that'd be 150. 3 is 100 beats per minute. 4 big boxes apart between QRSs is 75. 5 is 60. So this is right around just under 60 beats per minute, this sinus rhythm here. And 6 is 50, 7 is 40. So, boxology is one way to do it. If the rhythm is regular, that's a very acceptable way to get the rate. If the rhythm is not regular, then you can just count the QRSs on the strip. So I've numbered them. This is the same EKG, pretty normal, maybe a little borderline left axis deviation, maybe some left atrial enlargement. But so the strip is 10 seconds. So each of these, very dark lines is 1 second. And so 10 seconds, so you multiply the number of QRSs by 6. And as you can see, there are 10 QRS complexes in the 10-second strip. And therefore, the rate of this, the rate is around 60 beats per minute. So there you go. Okay. And then also important to remember that in sinus rhythm, you're going to have a P for every QRS, a QRS for every P. The P's should be upright in the inferior leads. So I'm just going to go back for a second. So if you look at the inferior leads, 2, 3, and AVF, those are the inferior leads. And you have an upright P, upright P, upright P. Those things all tell you that it's sinus rhythm. Technically, in sinus rhythm, you should have a biphasic P wave in V1. That most of the time is not going to be the case. The idea is that this sort of upgoing part is right atrial contraction, and the downgoing part is left atrial contraction. And if the downgoing part of that P wave in V1 is very negative, more than one box by one box, then that is often seen with left atrial enlargement. So just to kind of review some of the criteria for sinus rhythm. And then, so rate, rhythm, axis, QRS axis. So this diagram comes out from book Thayer, which is a good kind of easy reference. And so you can see that, sort of the vectors of your leads. So standard 1 is just 0, 2 is 60, F is 90, 3 is 120, R is minus 150, and AVL is minus 30. And if you draw the negative vectors of every lead, minus AVL, minus AVR, minus standard 2, minus standard 3, then you bisect the 360-degree circle in 30-degree wedges all the way around. So you make a perfect 360-degree circle bisected. And so then normal QRS axis is anywhere between minus 30 degrees and positive 90 degrees. And the best way, I think, to do that is to look at standard lead 1 and standard lead 2. So in any lead, if the QRS is more positive than negative, that tells you that the electrical vector is somewhere on that side of the circle, somewhere within 180 degrees. So if you look, for example, at standard 2 at 60 degrees, then and you have a positive QRS, then that's going to be anywhere between minus 30 degrees and plus 150 degrees. So it's going to be on this side of the circle. And if you look at standard 1 and it's more positive than negative, then it's going to be somewhere on this side of the circle. Okay, so I sort of detailed these, in terms of, what happens if, 1 and 2 are both positive. Of course, that's normal axis. If 1 is positive, but 2 is negative downgoing, then that's left axis deviation. Down in standard 1, but up in 2 is right axis deviation. And down in both is this thing called northwest axis in here, also called extreme axis deviation. Okay, so I'll just read some with you here. So we have a rate of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, about 66 beats per minute. Rhythm, so you can't see the P waves very well, but there do appear to be P waves for each QRS. QRS for each P, but of course, the big part of this EKG is this thing in here. And the question that of course arises, is this going to be some sort of atrial flutter pattern that's going through? And so, atrial flutter, as we've said in the past, is a macro reentrant arrhythmia of the right atrium, whereby which you have a circuit that basically goes around and around the right atrium at around 240 to 300 beats per minute. And it could create a pattern very similar to this. But if you have a very rapid atrial rhythm from the top chambers of the heart, then you should be in the setting of a normal AV node, conducting more when your atrium are going very fast. And if you march it, then you see that the QRS is overall pretty regular. And so that lets you know that probably these apparent flutter waves are artifact. And this is a classic sort of rate of artifact that you might see with a pill rolling tremor, for example, in Parkinson's disease or other things such as that. And this is something that we would often, potentially be called on in the middle of the night to look at. So here's another, sort of tricky flutter-looking EKG. So the QRS rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 times 6 is about 78 beats per minute. And it does, so the QRS axis is normal, upright in 1 and upright in standard 2. And the rhythm, of course, is the question in this. And so you got to use all your data. And in this case, the most obvious P waves actually are here in V2, and I circled them there. And so you can see that there is a P for every QRS, QRS for every P. And so this is another, the theme of this week, if it's not obvious at this point, is artifact. And there are EKGs where you can have a very regularized pattern of flutter conduction, but this is not that. This is artifact, and the way that you tell is you find those regular P waves, and so on and so forth. So this is probably the trickiest EKG of the artifacts, and these EKGs come from a website called you can Google Harvard Wave Maven, and they're probably some of the most challenging EKGs that you're going to come across there. Now here's a different one so the QRS rate 1, 2, 3, 4, 5, 6, 7, 8, 9. Well, let's do it a different way because we've been doing it that way each time. So here's one little box, 300, 150, 100, 75. So probably about 80 beats per minute is the ventricular rate. Looks pretty regular when you look at the QRSs in the rhythm strip, which often and most of the time is going to be standard lead 2. QRS axis is normal. So there you go with that. And then of course you have, especially if you look, for example, in V1 and certain parts of the strip, it looks like you have a very rapid atrial rhythm potentially, right? And so much faster than 300 beats a minute. Half of that would be 600 beats a minute. So maybe you could conjecture that there's an atrial rhythm with a regularized, sitting where the atrial rate is around 450 beats per minute. That's too fast for flutter. That's why I quoted that atrial flutter rate is 240 to 340 beats per minute. So this can't really be flutter. And then of course your next question is, could this be coarse atrial fibrillation? And the thing that tells you that it's not is these very upright, very regular, you can't see it very well there, but P waves in standard lead 2. So you can't have sinus rate and atrial fibrillation going on at the same time. And so this is a much faster artifact, and usually we'll see something like this in the hospital if somebody has a TheraVest on. So they'll be getting that rapid chest percussion, and you get a very similar pattern of artifact here. And of course, the key thing when you're thinking about artifact is looking for this regularization, this normality of the ventricular rate. So you want to really follow and march those ventricular complexes, the QRS complexes, that is. So there you go. And then of course, use all your leads. So the timing of the timing across here, every lead should be the same. Okay, so they're all occurring simultaneously. So if you see some atrial activity there, then draw a line down and see that it correlates with the atrial activity below in continue, at the same time in a different lead. And that is in fact the case here. So this is a more tricky one. I gave this at our conference at SQUA this year, and everyone immediately said torsades, which of course it looks like, because you have this apparent, sort of polymorphic twisting on points, looks like a wide complex tachycardia, but on closer inspection, when you see these narrow spikes, that connotes that there's probably conduction going down the native His-Purkinje system, down the ventricle. And you can't go up and down the ventricle at the same time. If you're going up the ventricle, you can have retrograde activity to the atria, and that's of course AV dissociation, and that'll tell you for sure that you're dealing with ventricular tachycardia. But this is actually another example of artifact, in this case mimicking ventricular dysrhythmia. So I marched out the QRS complexes for you there. And again, something that we would see on telemetry.
Toothbrushing.
Yeah, it could be toothbrushing. Exactly. Yeah, that's Sharmi said exactly. She knows very well. So, okay, a couple more things on EKGs here. So again, rate, ventricular rate, 1, 2, let's see here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. I'm making myself do harder math now, I guess. 90 beats a minute, ventricular rate. So 15 times 6, 90. The QRS is upright in 1 and down going in standard 2. So there's left axis deviation. And then the question is, why is there left axis deviation? And the reasons why there could be left axis deviation could be left ventricular hypertrophy. And some of the criteria you can use are down going RS in 1 or 2, plus the R in V5 or V6 greater than 35, which doesn't need criteria there. The other criteria that I like to use is the S in V3 plus the R in AVL, which supposedly is the most sensitive criterion. More than 28 for a man, 20 for a woman. Almost makes it, probably would be LVH if it was a woman by the criteria. But you also notice that you have this little Q in AVL and a little R in AVF. So if you draw a line in between them, they're like a mirror image of each other. And then you have just a little Q in standard 1 as well. And so that is sort of classic for left anterior vesicular block, which this is. So there are some criterion that I've listed for review here. You can't have a wide QRS consistent with a bundle branch block or an intraventricular conduction delay. You have to have a leftward axis greater than -45 and a QR pattern in AVL. But really, when I look at it, I look for a left axis deviation, and then I look for a QR and AVL and an RS and AVF, and what's most helpful is just to imagine a line in between the two such that it's a mirror, the AVL and F are a mirror image of each other. And that actually works pretty well for a posterior vesicular block as well. It's basically the same thing, except you would sort of reverse those two. And so remember that the left bundle is divided into 2 fascicles, the anterior and the posterior fascicle, color-coded here, for review. And of course, then those fascicles arborize into a very intricate His-Purkinje system for simultaneous ventricular activation through the conduction system via the left bundle in this case. Of course, the right bundle is pictured, but it's on the other side. And here's sort of what a left anterior vesicular block and a posterior vesicular block would look like. So blocking the anterior fascicle, you've got this QR in 1, QR and AVL, RS and AVF. Posterior vesicular block, kind of the opposite, RS and AVL, and QR and AVF. But again, if you look at draw a line between AVL and AVF, they're just going to be mirror images of each other in either case. So that's, vesicular blocks can be a little tricky, and hopefully that all sort of makes sense. But there's a couple of diagrams and some things to put in your back pocket, I suppose, if you come into the case where you have a left or right axis deviation without some other apparent cause, like right ventricular hypertrophy or left ventricular hypertrophy, and so on and so forth. So hopefully that's clear as mud. We can, if there's no questions on EKGs, then we can move forward to talking about heart failure with preserved ejection fraction. Huff puff. Let's fire away on that. So as you may recall, last time we had talked about heart failure with reduced ejection fraction. And now we're going to talk about the management of stable, not decompensated, stable heart failure with preserved ejection fraction. So I'll bring you through a couple of things that we had talked about last time. First off, what heart failure is and is not, a classification schema, talk about some disease mechanisms and phenotypes, and then of course the medical management of heart failure with preserved ejection fraction. So again, and this is really important, heart failure is a clinical syndrome, so you can't use an echo to tell that it's there. Manifestations primarily are dyspnea and fatigue, maybe limited exercise tolerance, and also very common pulmonary intersplanchnic congestion. So, some people will tell you they have new two-pillow orthopnea and have 2-3+ lower extremity pitting edema, and that's really, sort of a home run case for heart failure. And of course, if you check an echo and their ejection fraction is 25%, then it's like a home run, and that you don't need anybody like me to tell you that that's heart failure. Of course, then you have to put them on goal-directed management, so things like that. But when it comes to heart failure with preserved ejection fraction, it can be really hard. There's a lot of things that can sort of mimic it. And when I get a referral for new heart failure with preserved ejection fraction, the first two things I look at are their blood count and their albumin level. Because it's often the case that I'll have a case of suspected heart failure with preserved ejection fraction, and they are just getting a bunch of lower extremity edema because they're anemic for some other reason, or hypoalbuminemic for some other reason, and those aren't really heart failure. And of course, in that case, the primary manifestation tends to be lower extremity edema. And you can think about cases like postmenopausal women undergoing a sort of a normal course where they lose their hemoglobin drops 4 or 5 points after, for example, a C-section or something of that nature, and then they get lower extremity edema. Do they have heart failure? No, they have low intravascular oncotic pressure, which is pushing the fluid into the cellular space and creating lower extremity edema. And then, of course, there's other things: renal failure, lung disease, etc. And then, there's a number of other things that can mimic it: sepsis, burns, metabolic insults, etc. So heart failure with reduced ejection fraction, as you'll recall, is defined in the guidelines as, is this thing on the little dot? Yeah, move back to the dot. As an ejection fraction equal to or less than 40%. So it's not 45, it's not 50, it's less than or equal to 40 is reduced heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction is greater than 50, greater than or equal to 50. So if they're 50, 55 plus, then they have a clinical presentation consistent with heart failure. That's heart failure with preserved ejection fraction. And then this borderline group, I think that there's increasing recognition, as I said previously, that group, we're still defining the therapies for them because they don't necessarily fit neatly into the HuF-Puff or the HuF-Ruf. And the tale of today's talk of heart failure with preserved ejection fraction, when you really manage these people, the biggest issue is that this is a really heterogeneous group, much more heterogeneous than heart failure with reduced ejection fraction. And even in that case, there's subdivisions, there's ischemic and non-ischemic, etc. In this case, there's just a tremendous amount of phenotypes of this disease pathology. And so the best we can probably do moving forward in the path of sort of heart failure specialists is to really focus on these specific phenotypes. So the first thing you want to do is at least subdivide them this way. Now, that being said, these heart failure with borderline or improved ejection fractions usually we then lump them with the huff-puff people in terms of, you know, what we think works for them in goal-directed medical therapy. If they have improved ejection fraction but previously reduced, then I usually will treat them like a huff-rough. In other words, there's a lot more therapies that I think are effective, and I keep them on those things. So let's go through those things. And then the classification schema, as we previously alluded to, there's stages of heart failure, and there's a functional classification of heart failure. And this is mostly a reference slide, very busy. But stage A is they're at risk, but they don't have any clinical manifestations. Stage B is maybe they had an MI and their EF's 40%, but they don't have any clinical manifestations. Stage 3 is they have overt clinical manifestations of heart failure. And then you can subdivide that into they have no functional limitation, NYHA functional class 1. They have a slight limitation, meaning they can get up 2 flights of stairs before they get dyspneic, but then with higher levels of exertion, they do get dyspneic. And stage 3 is they can't get up 2 flights of stairs before they become dyspneic, but they don't have symptoms at rest. And then stage 4 is rest symptoms, and that they quickly go from a class C, which is, you know, you're doing all the usual stuff and you can control them, to a class D, meaning that you've done everything you possibly can for them, and they're still requiring, for example, specialized interventions, and you're thinking about things like ventricular assist device, perhaps heart transplantation, et cetera, and so on. So the functional classifications follow reasonably ASA classifications, and therefore, you know, I put this slide in to sort of highlight visually those functional classifications. All right, so now we're kind of getting into the nuts and bolts of heart failure with preserved ejection fraction. So the whole point of this slide is that relaxation, not contraction of muscles, including in the cardiac myocyte, is the energy-dependent process. So you've got your myosin head, adenosine triphosphate is split into ADP, diphosphate, and another phosphate group. Then that head cocks itself and causes muscle contraction. Energy's already been used. The muscle contracts, and then the actin-myosin complex sort of dislodges, so that myosin head comes off of actin, and then with relaxation, ATP is bound to the myosin head and uncocks it, relaxation, splitting the ADP into ATP and into ADP and another phosphate group. So, you know, I think about rigor mortis, you know, you're devoid of cellular energy levels and you have a stiff, rigid musculature. And so this is really important in the case of heart failure with preserved ejection fraction, because one has to remember that if for some reason you have a process by which this myocyte is really struggling, a myopathic process, that could be most often systemic hypertension causing thickening of the left ventricle. It could be ischemia causing poor cellular energy storage of the left ventricle, and your energy poor in the cellular myocyte compared to the workload required, that it's actually the first thing, you know, one of the early things that's going to happen is that you're going to have stiffening of that muscle, and that will cause the clinical disease state of heart failure with preserved ejection fraction. So these are some things from the guidelines. This highlights the idea that relaxation is the energy-dependent step of muscle contraction, the idea of restoring forces, and that you really have to push that blood flow from the left atrium into the left ventricle. And if there is increased stiffening, then you're going to have, you know, a backload and a transmission of pressure into the left atrium and therefore into the pulmonary vasculature. So, you know, in cardiology, we love hemodynamics, and this is a tracing of, you know, the left ventricle, the pressure waveform in a left ventricle, the left atrium, and then we put them together to highlight the idea of what in the heck is actually happening during filling and diastole, right? And so you have this A wave, you have early filling and late filling. So the idea is that if you put the left ventricular and the left atrial waveform together, when the left ventricular waveform is higher pressure than the left atrial, the left atrial waveform is higher than the left ventricular waveform, then the ventricle fills. So the atrium has to be higher pressure than the ventricle to get the blood into the ventricle. And that happens in two phases. An early phase, early filling, and that is passive. So blood's just coming in. And then a later phase marked by atrial contraction, and that is called the A wave. So E wave and A wave. And this is something we measure on echo. So if you look at echo, you can see, well, I should first say that echo is not just a tiebreaker to diagnose heart failure, as we've said before, but it does, you know, tell us about filling, and we get a lot of useful information from it as an adjunct to clinical decision making. But if you look at an echocardiogram, you can see the phases of, you know, this pressure waveform of filling of the left atrium and the left ventricle. So what we do is we put a little, we sample what's actually happening at the mitral leaflet tips to see, you know, how that mitral valve is opening. Tells us about how the filling of the left ventricle is happening through the mitral valve, of course. And then we put a little sample on the muscle at the proximal interventricular septum, and then also the lateral wall, and how, if it's relaxing, then of course the muscle is going to expand outwards, but also there's translational motion and will go up and down with healthy contraction of the muscle. So when we do that, the best way to do it is really with a tissue Doppler, because the reasoning is that tissue Dopplers are less sensitive to the volume load at that time. So in other words, if you're acutely volume overloaded, your E wave and A wave at the mitral leaflet tips is going to change, but your tissue Doppler should not change based on your volume status. So, but in either case, the idea is that there's two phases of ventricular filling, an E wave and an A wave, and when we're measuring tissue Doppler, we call them E prime and A prime. And so those things guide us in diagnosing heart failure with preserved ejection fraction. They give us some echocardiographic parameters of how well this ventricle is filling. And so, oh, there we go. So then we also measure those at the leaflet tips of the mitral valve, and we see at early filling and in later atrial contraction, which is the A wave. So anyway, so there's some echocardiographic parameters that we use for these things, but what we're really talking about is this problem of, you know, progressive pulmonary venous hypertension. So the first thing that happens is a myopathic process in the left ventricle, okay, in the setting of heart failure with preserved ejection fraction. And then that pressure is back transmitted to the left atrium, and with chronic constant pressure overload, we're measuring the size of the left atrium, which will dilate if there's a myopathic process in the left ventricle. And so that's why some cardiologists call the left atrium the hemoglobin A1C of the heart. And so a normal volume index, just for your reference, is less than 34 milliliters per meter squared, and that'll be reported hopefully in your echocardiogram report. Especially if it's abnormal, you're going to see a number there that tells you about the size of the left atrium as a surrogate for the health of the left ventricle. And also, not only as back pressure transmits into the left atrium, also as that happens, as the atrium dilates, there's also back pressure transmitted through the pulmonary veins into the pulmonary circulation. And that, of course, is what's going to cause pulmonary edema and ultimately pulmonary hypertension. And 80% of people who have true heart failure with preserved ejection fraction, they will have measurable pulmonary hypertension on their echocardiogram. So an RVSP over about 40 millimeters of mercury. If you're reading that echo report, the RVSP is over about 40, then that's sort of where we start pulmonary hypertension. The true diagnosis of pulmonary hypertension is a mean pulmonary pressure greater than 25 millimeters of mercury. And of course, you need the pulmonary diastolic pressure for that, and you have to have, there's some other ways we can get that on the echo, but just use an RVSP over 40. And that's going to be true in 80% of people by studies who have heart failure with preserved ejection fraction. All right, so that's, kind of what it is, how to diagnose it a little bit, what things you might look for on your echocardiogram report, which are sort of confirming your clinical suspicion that this thing is happening, right? So then what do we do about it? So there's some risk scores. I'll go over these at the end. I put them at the end just, depending on time, I could review them. But you can tell people about their life expectancy and things like that. And I think most cardiologists' favorite is one called the Seattle Heart Failure Score right here. So that's in the guidelines. I have a slide on that at the end. But, so risk stratify them. And then what do you do for heart failure with preserved ejection fraction? Well, the real deal of treating this group of people that you can say for everyone is really based on comorbidities. So as I said, the most common clinical scenario that you're going to run into is hypertensive heart disease causing left ventricular hypertrophy and heart failure with preserved ejection fraction. So of course, if blood pressure is the problem, then fix that with medicine. And generally you're going to jump to ARBs, maybe ACE inhibitors, and beta blockers. But unlike heart failure with reduced ejection fraction, it's not necessarily true that you just have to use Coreg, bisoprolol, maybe nebivolol, and long-acting metoprolol. You can use short-acting stuff too. So you have a few more tools to tackle that stuff. And if you're wondering about all these medicines and doses, just refer back to my last heart failure with reduced ejection fraction, where I gave this really onerous slide about all the medicines and doses and what's worked in clinical trials and all this, where you start and how much you use, all that stuff. So first thing is treat their blood pressure. So class A, level of evidence B, it works for people. Second thing is, if they're fluid overloaded, give them some diuretics. Start them on some Lasix, and if that doesn't work, there's various other things. If you think that they have a lot of splanchnic edema, you may want to use Bumex, because that is much more effective in that circumstance. And just remember that Bumex has a longer half-life, etc. If somebody's coming in, they have anginal chest pain, and they have clinical syndrome of heart failure, then you can consider revascularization for the purpose of on top of medical management, for the purpose of improving their heart failure symptoms, and maybe that works. Level of evidence C, so not very good evidence. So there's not very good evidence for anything in heart failure with preserved ejection fraction. So, it's art of medicine kind of disease process. manage their AFib in conjunction with guidelines. I'll tell you, guidelines are probably it'll be interesting to see how they change. Just, what's today? That just 7 days ago in the New England Journal of Medicine, we found out that if you do an AFib ablation, at least there's some randomized controlled evidence by the Castle AF trial that will improve their heart failure. And so, we'll see putting that into the body of other evidence if the guideline writers think that that's something we should consider more. So we said beta blockers, ACE inhibitors, and ARBs are preferred agents in heart failure with preserved ejection fraction. ARBs might decrease hospitalizations, and nutritional supplements don't help, unfortunately. So it is what it is. And so this is kind of the same thing, breaking it down one by one. Control their blood pressure, give them loop diuretic or other diuretics to decongest them, revascularize them on top of goal-directed medical management, maybe, and rate or rhythm control their AFib. Again, art of medicine there. When you're using antihypertensives, think about beta blockers, ACE inhibitors, and ARBs. ARBs might reduce hospitalizations, and supplements don't work. So comorbidities. I mean, if it's all about comorbidities, we got to know what they have. And so if you have a younger patient under 65 with heart failure with preserved ejection fraction, these are their most common comorbidities. I will say that when it comes to anemia, because of their, for various reasons actually, it can be somewhat difficult to get, if they have iron deficiency anemia, to get their iron stores up, especially with just regular old oral iron that we often use. And so if you've tried that and not been successful, IV iron is often required. And if they happen to be hospitalized, which hopefully they're not, but if they are, then the easiest way to get that is in the form of blood, because ferritin's pretty expensive. And then, lower their blood pressure for their kidney disease, treat their diabetes and lipids and COPD and asthma, etc. If they're older and this setting of heart failure with preserved ejection fraction is much, much increased in prevalence amongst people over 65, treat their blood pressure. Their likelihood of ischemic heart disease is very high, 70%. So think about that, and ischemic evaluation, lipids, anemia, diabetes, all of the same things. AFib is much more common in people over 65 with heart failure. And then, of course, always we have to worry about cognitive impairment and how that interacts with everything else. So manage the comorbidities. All right, so that's the general thing with heart failure with preserved ejection fraction. I want to go over a couple other things since it looks like we do have some time. First off, we talked about these risk stratification models. This is the guidelines Seattle heart failure model. And so a lot of times this will come into play if if we're considering, for example, a defibrillator, we say, well, are you going to live long enough to make this thing worth it? That's in systolic heart failure, of course, or ventricular tachycardia. But if people want to know, you can plug the numbers in. Even with heart failure with preserved ejection fraction, mortality is pretty high, unfortunately. All comers, it's generally about 50% in about 7 years. Even in 2018 with all the therapies that we have. So you can plug in age, weight, ejection fraction, medicines. This is for systolic or diastolic heart failure, obviously, so hence the EF of 30. You can put that in. Lab tests, medicines, devices, weight, and then it'll give you, an average, expected clinical course and mortality. Now, if they're admitted with heart failure, this is an alternative model that's been validated. This is the one that the guidelines allude to, and you can sort of add up all these points of their age and their sodium. So if they're hyponatremic, that's harder for them to get by. If they're over 110 years old, it turns out that also they die at a higher rate. So I don't know how they got data for 110-year-olds, but hey, what the heck. So there's a couple of things that you can look at, and again, they're in there for reference. You may have to search for this tool a little bit more through the American Heart Association's guidelines, but it's in the slides for reference should you want it in the future. But those are the ones that the guidelines refer to. So we talked about beta blockers, ACE inhibitors, and ARBs. But what I did not talk about, what is not in the guidelines, is aldosterone antagonists. And amongst most heart failure specialists and cardiologists, our belief is that actually spironolactone does improve outcomes in heart failure with preserved ejection fraction. That was not borne out in the trial that I'm referencing, which is called the TopCat trial. It was a randomized controlled trial of spironolactone versus placebo for patients with heart failure and an EF at least 45% or more. The primary endpoint was any cause, cardiovascular cause of death, aborted cardiac arrest, or hospitalization for heart failure. And if you look at the event rates of, we would want to lower event rates and look for a curve like this in a Kaplan-Meier plot with spironolactone versus placebo. It was a total wash in the trial, but as always, the devil's in the details. And little personal disclosure here, despite the fact that my name's Ivan, I have no Russian in me. But when I trained at UC Davis, the Russian patients would see my name, Ivan, and they'd be like, oh, we got a Russian doctor here, we should go see him. And so I became very familiar with Russian patients, and they're wonderful people who often emigrated to the Sacramento area because they were fur traders, of course, along the Russian River. But what I've discovered in treating those patients is that they have a huge tendency towards sort of homeopathic remedies. And if you give them medicine, they may reject it. And what was found, it turns out, in sub-analysis of this TopCat trial, which was done in the United States and Canada, North America, South America, and Russia. And so the Russians, turns out, weren't taking their medicine. And so they looked at people who said, and if we could zoom in on B, said they were taking the medicine, but they detected this metabolite of it called canrenone. The people who had no detectable canrenone, i.e., you said you're taking your medicine, but you're really not, were way higher in the Russian group than in the United States and Canada. So there, amongst the group, there were more of those people, and that was definitely significant. So the Russians weren't taking the medicine, and then if you look at the supplemental indices of event rates in different populations, and you look at the United States, remember that the 95% confidence interval in parenthetically there tells you, sort of we're 95% confident that this lowered event rates if you don't cross unity. And so it was 1.01, so if it's over 1, then it's abuts, the fact that we can't be 95% certain that it did work, but it pretty much did. I mean, it reduced event rates of, again, death, hospitalization, and cardiac arrest by about 16% compared to placebo, which is pretty good in a disease where nothing works. And that was true in the US. That was not true anywhere else. So if you look at Russia and Georgia, if you look at sort of all these other sites, Europe and East Asia, it didn't work at all. So the average was no effect whatsoever, maybe a little worse. South America maybe worked with a very wide confidence interval, probably a few less patients maybe in that population, and so on and so forth. So the result of all that is that most heart failure specialists do believe that spironolactone does work in United States patients for heart failure with preserved ejection fraction. It's one of very few things that does work. So I'll end with that. It's not in the guidelines, but that's a sort of it's something that works. It's well worked into practice. Most cardiologists are using it.
So there's a question here. Are
Yeah.
there certain cases where you use spironolactone in conjunction with Lasix?
So the classic case of spironolactone and Lasix is for ascites. And in the case of ascites, usually the ratio is 50 milligrams of spironolactone to 20 milligrams of Lasix. And the reason for that only is that you balance potassium in general with that ratio, 50 to 20. And so I think if you can decongest them with 50 milligrams of spironolactone and 20 of Lasix, if 20 of Lasix is all they need, then absolutely I would use those together. I think that's a fine strategy. And again, there's no hard rules here because nothing really works that well. So there you go. So now I will say, there are subsets. I talked about the most common subset of heart failure with preserved ejection fraction, which is hypertensive heart disease leading to HFpEF. And then you control their blood pressure and do all this stuff. But the second most common subset of people, and the one that you should also keep a good eye out for, is your little old lady, little old guy, who maybe has a small ventricle and a thickened LV, and maybe some renal insufficiency. And in that case, they can have cardiac amyloid. And so there's immunofixation assays that you would use to diagnose that. But there's actually a nuclear stress test called a pyrophosphate scan that is, by emerging studies, almost perfectly sensitive and specific for this stuff. And so I think that those are the people we can treat their amyloidosis. In that case, it's a transthyretin amyloid that goes along with that. That can have great benefit. So that's going to be a real minority of cases, but in a group of people who is very difficult to help, that patient is a good one to find in the haystack and get them, get their amyloid treated for the purpose of improving their heart failure or maybe resolving it. So.
And actually, I have a question.
Yeah.
Is sleep apnea a risk for HFpEF?
So sleep apnea, I think, more complicates HFpEF because, as we said, with people who have HFpEF, that 80% of them are going to have echocardiographic evidence of pulmonary venous hypertension going. And if you have chronic pulmonary venous hypertension, you're going to get a fixed component because you're going to muscularize that pulmonary vasculature. And if you hit that again with sleep apnea, which is really common in obese patients who are very much at risk for HFpEF, you hit them with 2 insults on their pulmonary vasculature, and then they're just tremendously dyspneic. So Sharmisa's point is excellent, and it's not in the guidelines as one of the top comorbidities, but definitely have a very high index of suspicion for sleep apnea in anyone with heart failure, including heart failure with preserved ejection fraction, because that is a very important comorbidity to treat. So thank you, Sharmisa. That is an excellent point, I think.
And another question, exercise in these folks.
Yeah, so it's good. It helps. The idea is that as you exercise, you increase the plasticity, the elasticity of the left ventricle and improve their filling protocol. So I believe in exercise always for heart failure, but it's not per se guideline directed stuff, but I mean, it definitely helps, and you should absolutely have them do it because you can train them quite well. So that, yeah, excellent points on both cases. So, well, anyways, yeah,
Tom.
Yeah, hi there. Tom Berg, Eli Lilly Medical Affairs, supporting research and education. Quick question about maybe modes of death or decompensation related to reduced ejection fraction patients and the preserved. Are the preserved ejection fraction patients predisposed to arrhythmic death, ventricular arrhythmias, things of that nature?
Less so. I mean, certainly that is true. And as you saw with the Top Cats trial, that's an important mechanism of death. But in general, with preserved ejection fraction, you're going to be more likely to have pump failure death. And that's definitely true at the end stage with systolic dysfunction. But if you have systolic dysfunction, especially if it's ischemic systolic dysfunction and you have a big scar, that's why if your ejection fraction is 35% or less, that buys you primary prevention of arrhythmic death with a defibrillator anyways. And there's no indication apart from sustained or symptomatic ventricular tachycardia in the case of heart failure with preserved ejection fraction for implantation of a defibrillator. So definitely can happen, but I think that it's just, the way I think of arrhythmia in these people is like the same way as you have a PEA code in a young woman who is on a transcontinental flight or maybe just had surgery, has a huge, massive PE, then they get tremendously hypoxic, and all the H's and T's can always stack to cause an arrhythmic death or a code. But in the case of heart failure with preserved ejection fraction, my view is that the primary insult is pulmonary edema leading to poor gas exchange from pump failure, and that then triggers more likely arrhythmic death, more likely. So excellent question. Yeah, I think that's something we have to keep in mind too. So, and remember, I will say that it's amazing if you're going back to the systolic heart failure thing, a lot of family members of people who have a defibrillator don't know how to do CPR. And they don't know they may not even need to do it. If you don't have adequate cellular stores of ATP, you can't shock that heart back. You got to pump that thing and get the energy to the heart muscle in the case of arrhythmic death before that defibrillation is going to work, which is the mechanism by which that's the reasoning for the change in the guidelines of give them CPR, then shock them. I mean, you want to get it all done as soon as possible, but in the setting of a bystander arrest. So it's a failure of cardiologists and electrophysiologists, but as clinicians on the front line, it's always good to ask your patients if they have a defibrillator in, if their family member knows how to do CPR, because many will not. So
we have a question in Elko.
Yeah.
I missed part of what you were saying about exercise. My name is Becky. I'm the director of cardiovascular services at the hospital here in Elko.
Yeah.
We're having a lot of patients be referred to our cardiac rehab program who have HFpEF.
Yeah.
Most of them have CAD as well.
Yes.
We are seeing them a lot. We don't know if there's any studies regarding the benefits of cardiac rehab specifically to HFpEF patients.
Yeah, there are, and heart failure is a subgroup of, that definitely is known to benefit, and it's in the rehab guidelines to exercise them, especially with coronary disease. In our rehab, it's been hard to build the capacity for those people, but it definitely improves mortality and symptoms. So absolutely. And there's a body of literature on that.
Yeah, we're trying to promote it. We just have a couple of doctors that they don't believe in the credibility of cardiac rehab. Naturally.
I mean, a person adapts to the, the idea that they have. And to be fair, cardiac rehab as mortality preventing death, there's one study that shows that it does that. If you look at the meta-analysis, it confirms that there is mortality benefit to cardiac rehab, even in people with established coronary disease. But it's so, because the problem is that there's a tremendous amount of selection bias in people who attend cardiac rehab, and so it's hard to work through that. But from people who are really enmeshed as I am in the patients who go through cardiac rehab, they feel so much better, so much better. So.
Absolutely. The other thing we're trying to sell to them is there is studies, not maybe mortality, but related to less readmissions. And that's what our goal is trying. At least a lot of these people don't have PCPs.
Well, because you can catch them. You can catch their out of control dyspnea if you're exercising them and watching them closely, and there's better oversight. So encourage your clinicians. What can I say? We all have to fight for what's right. On the side of the question from Winnemucca about physical therapy in the setting of heart failure with preserved or reduced ejection fraction, I view that as more of a mobility issue. So if your heart failure patient who often has comorbid mobility limitations would benefit from physical therapy, I would use it. Outside of that, they need pretty rigorous physical activity to benefit, like in the case of cardiac rehab. And I'm not sure that regular routine physical therapy is sufficient. So that's the way that I look at that. So wonderful, everybody. It's 9. I hope you have a happy and productive work day. And if you have lecture topics that you like to see presented, everything's negotiable. Let me know and I'll adapt them accordingly. Thanks for attending.
Thanks, everyone.
Thanks very much.